the month of World Sepsis Day, which happened last week on the 13th of September. And I thought it'd be a fantastic idea to look at sepsis in a few different lenses. So I purposely invited two nurses who I have the great pleasure to work with, three actually, that I have the pleasure to work with, to take away this journal club, and I'll let Fiona introduce them. And then I'll finish up with some new, to discuss the clinical care standards and the updated sepsis coding, which will actually have significant impact on our surveillance, obviously. So take it away, Fiona.
Good morning. Thank you, Kaz. And I would like to begin first by acknowledging traditional owners of country throughout Australia and paying respects to elders past and present. And I'd like to extend that respect to Aboriginal and Torres Strait Islander people who are here today. And welcome everybody to the webinar. Got a great program this morning. With a focus on sepsis. And first up, we have a PhD candidate and nurse, Alison Lemoh. Alison has started her PhD pathway just this last year, and she's at the Peter MacCallum Department of Medical Oncology, which is part of the University of Melbourne. So Alison has worked in intensive care for over 20 years. She's now an intensive care unit outreach nurse consultant, and she's part of the medical emergency team at Peter MacCallum. Alison's research is focused on the role of nurses in recognition and response to sepsis. And through Alison's research, she's hoping to gain some insight into some of the experiences and unique challenges of nurses from diverse linguistic and cultural backgrounds, and those working in regional, rural and metropolitan contexts. Something interesting about Alison, alongside her nursing career, she has also completed undergraduate and master's degrees in music in the specialty of classical voice, and that was at the Sydney Conservatorium and also the Victorian College of the Arts. So these programs for Alison continue to inform her approach to transdisciplinary research as she navigates her PhD pathway. So welcome to Alison, and looking forward to hearing this presentation on implementation challenges in sepsis and the role of the nurse, past, present and future.
Thanks, Fiona. Thank you. Good morning, everyone. I will just go to screen sharing. And sorry, I'll just trying to go into my presenter mode. Sorry, I'm just having difficulty finding the presenter button. It's covered by the Zoom. Is this vision, is this okay like this?
You can move the Zoom bar. If you click on the Zoom bar, you should be able to move it, so then you can.
How do I
Because
click?
where you don't see the Zoom bar.
Alison, yeah. Or Alison, just go along the top of your PowerPoint and just along from EndNote. There's EndNote Help, then there's View, and you should be able to view your presenter view there.
EndNote View.
Along to the, keep going along to the right. Yeah. Keep going left.
Or underneath that slide, down the very bottom next to the volume slide, you can also press the view, the little computer looking button as well down the bottom.
I've got tech support, so down here.
Yeah, so 2 along, 1, 2, and then the last keep going. Down again where you were. Down, 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 just to the right. Yeah,
there it is.
Click that.
Oh, perfect. Thank you so much, Belle. Thank you. Sorry. Showing my age with computers. So my talk today is implementation challenges in sepsis and the role of the nurse, the past, the present and the future. And my primary supervisor is Professor Karin Thursky. Today, I just thought I'd actually talk a bit more about the history of sepsis care in nursing, and then looking at what we do now, and then a little bit on the future, because it's still a bit of an unknown. So just going a little bit back, Florence Nightingale, in her notes on hospitals, said as the very first requirement of a hospital that it should do the sick no harm. And I think that still stands very true. So just now looking back into the past, this is Edvard Munch's The Sick Child from 1907. He actually lived a very long life, but witnessed a lot of suffering in his time. This is Gustav Mahler, who was a composer. He was a brilliant composer and conductor, and he became artistic director of the Vienna Court Opera in 1897 at the age of 37. He was the eldest survivor of 14 siblings, 8 of whom died in childhood, and the 9th later committed suicide. He also lost his daughter to sepsis at age 5 from a strep throat-related illness. He was a very fit man, but suffered recurrent bouts of tonsillitis as a child and developed rheumatic fever. I'm just talking about him because my music thesis was actually about 2 of his songs, and one of them's At Midnight, which is where the protagonist describes being awake at midnight and feeling the pulse of his sick heart and unable to win the battle against his suffering. And also the opening bars of his Ninth Symphony are a rendition of his heart murmur that he developed because of endocarditis. And there's a loud whistling sound on the second beat. So a life before sepsis care and antibiotics, Mahler developed endocarditis in 1910 while working as conductor of the New York Phil. And he was found to have fever, pallor, splenomegaly, loud cardiac murmur, clubbing and conjunctival petechiae. They took some blood cultures, which was quite a novel thing at the time. And that showed Streptococcus viridans endocarditis, which affects the damaged fibrosed valves from chronic rheumatic fever. He then consulted with his friend, Emanuel Liebmann, who was a pianist and accomplished physician and was also an expert microbiologist, who actually studied with Theodor Escherich, who discovered E. coli in 1885. And he advised Mahler of his prognosis. So Mahler went back to Vienna and was treated with experimental serums, oxygen, caffeine digitalis, and radium to his swollen joints. I think he was bled multiple times as well. But unfortunately, he died at midnight on the 18th of May at the age of 50 years. And his last words were Mozart, Mozart. Just a brief history of hospital sepsis care. I went down the rabbit hole of looking into what we used to do. So 1300s to 1500s, there was a 90% hospital-acquired infection rate. And the hospitalisation-associated death rate was between 40 to 70%. And therapies for infections included ground rabbit fur and mummy powder. So they actually ground up mummies. Then the 1500s to 1800s, there was lots of things, emetics, mercury, quinine, bloodletting. Quinine might have helped if it was malaria. And the hospital-acquired infection rate was around 60%. And the inpatient death rate was 10 to 40%. There was no hand washing or cleaning of surgical instruments, and healthcare workers had an estimated 8% mortality rate. Then in 1840s, Semmelweis, who was a physician, he observed a high rate of maternal sepsis in doctor-run obstetric clinics, a particular clinic, and there was an 18% mortality rate. Whereas Clinic 2, which also worked in the same institution, had a 2% mortality rate, and it was run by midwives. He noted that doctors and med students didn't wash their hands between the cadaver dissections, and then they went straight from doing dissections to going and doing obstetric examinations and deliveries. So he prescribed hand washing with chlorinated water, and they found that the maternal death rates actually plummeted down to the midwifery clinic rate. Apparently, unfortunately, he was not very socially adept, and he sent lots of abusive letters to surgeons and other people about washing their hands, and he became very unpopular. And he ended up being committed to an asylum at the age of 47, where he actually died of sepsis, possibly from being beaten up. Florence Nightingale and infection control, she developed her environmental theory from the Crimean War in 1854 and arrived with 38 nurses to Crimea, and there was initially 3,000 soldiers on straw beds across stone floors, which stretched 6.4 kilometres through the barrack hospital. Infection was rife. Cholera, typhoid, typhus, respiratory infections and dysentery accounted for over 50% of deaths. And there was a 4 times higher rate of death within hospitals than actually on the battlefield. There was no concept of microbial infection, but there was awareness of contagion, and they had a miasma hypothesis, which was inhalation of infection, which, has some validity. Nightingale enforced health of houses, pure air, pure water, efficient drainage, cleanliness and light, and that were essential to healing. And she made her nursing team ensure clean bedding, wound dressings and healthy food. and also implemented distancing between patient beds. So 21,500 soldiers died in Crimea, and 79% of those were from infections and other diseases. Just going on to the present now. Our current global burden of sepsis is 48.9 million cases, and we have 11 million deaths per year, and 1 in every 5 deaths worldwide are associated with sepsis. 85% of those occur in low or middle income countries, and 2 out of every 5 cases are in children under 5. Sepsis is a disease of poverty and inequality. Low and middle income countries, there's 140 countries with 6,248 billion people. And in high income countries, we've got 119 billion people. And as we all know, low and middle income countries, deficient primary health services, poor sanitation, and inadequate control of chronic disease, which contributes to caseload. Also, there's a rife history of colonial rule, political corruption, driven from external and internal forces, misuse and abuse of local resources by national and international powers. Just to give a little outside the bubble of Western affluence, sepsis in West Africa, just reading an interesting book on by Paul Farmer, who went to West Africa and worked with the Ebola crisis. They found there that they only took 1 set of bloods, which was for PCR purposes, for diagnosing Ebola, but other labs were not done because of the fear of transmission. And there also no IV fluids were given, which would have saved thousands of lives, because again, the fear of transmission. So despite doing venipuncture, they wouldn't put in a cannula because of the policy and protocols around contamination risks. So people were given oral rehydration fluid, and if you were too sick to drink that, then you would die from dehydration and electrolyte loss. There was 11,310 total deaths, and around 1,000 healthcare workers died from Liberia, Sierra Leone, and Guinea. Fell ill with Ebola, and over half of those died. And every American, except for 1 Liberian-born US citizen, and most of the European healthcare workers survived when they contracted Ebola, because they were airlifted out to receive supportive care in a high-income country. It just reiterates the importance of some very simple supportive cares that we can do to prevent death. Sepsis and implementation in Australia. We currently have no implemented standardised approach, either statewide or nationally, to the early recognition and management of sepsis in the Australian healthcare system. Safer Care Victoria has given us an adult sepsis pathway implementation toolkit, and we now have the National Clinical Sepsis Care Standard, which Professor Thursky will be talking about, which was released in June this year, which will hopefully make a huge difference to how we manage sepsis in Australia. There are ongoing debates around what the best evidence-based practice is for sepsis management, but we do know that having a sepsis improvement program is probably more important than the actual contents of the program, according to current research. A 7.5-year study of 280 hospitals found that hospitals with high compliance to an improvement program had a sepsis mortality rate of 29% versus low compliance hospitals that had a rate of around 38.6%. And an Italian study also found that a dedicated sepsis response team increased bundle adherence from 4.6% to 32%. And initial empiric antibiotic prescribing was more appropriate. It went from 30% to 79% in appropriateness. Nurse-initiated early sepsis care. Nurses have sustained patient contact. We are very well placed to identify deterioration and initiate care. It also, research shows that nurse-initiated care has a reduced time to antibiotic administration, reduced ICU admissions, reduced cost, and reduced sepsis-related mortality rates. Nurses are coordinators of care, and we attend multidisciplinary rounds. We meet families, we navigate patients' social support systems, and we get to know their cultural preferences. There's very strong evidence as well that optimal nursing ratios are linked to patient safety. And working to full scope of practice will increase nurse recruitment, retention, and career satisfaction, which is a very good thing. Just talking now about the future, I really like this image because it really gives the nice panorama of the different roles of nurses and also puts in the social and political and cultural contextual issues as well. The future of nursing in sepsis care, this is by no means an exhaustive list. Development of more sepsis nurse practitioners. Peter Mac has very lucky to have an ID nurse practitioner, Belinda Lambros, who will be presenting after me. They help to drive recognition and management, early recognition and management, and support patients through hospital stay, and will help to ensure community follow-up as well. Survivorship is emerging as a really critical part of sepsis management. Enabling nurse-prescribed first dose empiric antimicrobials. This happens in some hematological contexts, and where there are pre-charted first dose antibiotics in Australia, but we do also, I think in England, they actually already have some first dose empiric antimicrobial prescribing from nurses. Predictive analytics, use of historical data to forecast future patient events and behaviour. Nurse-led education hubs devoted to sepsis education, AMS and survivorship, and we're kicking off a hub here of that kind of nature. Identify and prioritise evidence-based interventions with proven mortality benefit. That's an ongoing challenge for all clinicians and researchers, and everyone's working very hard. Appropriate and climate-friendly resource allocation to populations and countries most in need. Finally, just a little hammer over the head from me. Equity and a fair go for all. Part of my research is really to design an implementation framework that meets the needs of diverse clinician and patient populations. I'm a big Monty Python fan. Terrific Race the Romans, terrific. The Australian Institute for Health and Welfare states that greater than 34% of the health gap that exists between Indigenous and non-Indigenous Australians is due to social determinants. It's 2018. Inequalities in sepsis incidents in Australia. Incidence of sepsis hospitalisations is a 1.7 times higher incidence for those living in remote areas compared to metropolitan areas. Sepsis incidence is 1.7 times higher amongst Indigenous people, and there's also 1.2 times higher incidence amongst people living in the poorest areas compared to the richest areas. And a very lovely quote from Arundhati Roy. We know, of course, there's really no such thing as the voiceless. There are only the deliberately silenced or the preferably unheard. Thank you. This painting, I just went to the Picasso exhibition yesterday at the NGV, and this was done by Picasso 3 years before he died, and it's a bullfighter, and it sort of shows his defiance of fear in the face of death and the vitality of life that we keep fighting for. Thank you.
Thank you, Alison. Okay.
Question? Yes, no, I just wanted to welcome online Professor Mai Krishnasamy as well. I can see you're there, so please feel free to comment, Mai, as well. She's a professor of nursing, works with me at Peter Mac and also at the university. I love listening to Alison talk because you very rarely see this humanities lens through some of the things that we do. Alison, speaking specifically on some of the issues around nursing roles, can you tell the audience your, this is going back to this, you know, I've talked a lot about implementation and the importance of implementation before to the audience here, how you're going to approach the challenge of understanding the role of the nurses and how they can best function.
Yeah, so what I'm going to be doing is I'm going to do a knowledge, practice and attitude survey across Australia, a national survey, to try and find out the current practice with sepsis and really what the differences are between metropolitan context, regional and rural context. And then I'm also going to try and find the sort of cultural and linguistic diversity challenges experienced by people who trained overseas and in Australia, but with linguistic differences as well. To really see what we can do to improve the nurse's role and a team response to the early recognition of sepsis.
Thank you, and we really look forward to the next iteration of what you come to us with, Alison. Fiona, do we have time for any more questions? We might need to keep moving. Have you got any questions?
We may need to keep moving. I think, you know, if we have time at the end, I'd like to talk a little bit more, perhaps, Alison, about implementation and perhaps some of the priorities for those low and middle income countries and regions. See how we go. But in the meantime, I will hand over now to Belinda Lambros, who's a nurse practitioner at the Peter MacCallum Hospital. And Belinda has more than a decade of experience in working at Peter Mac. She's worked in various roles throughout critical care, cancer experience research, and she's also worked in specialist nursing. But in December 2020, very exciting time, because Belinda was appointed the first ever nurse practitioner in infectious diseases and antimicrobial stewardship. So she is a leader and champion. This role supports Peter MacCallum patients in both the inpatient and ambulatory settings, and key aspects of the role are, of course, sepsis pathways, low-risk febrile neutropenia, the ambulatory program there, and antibiotic allergy assessment and delabeling, as well as antimicrobial stewardship, vaccination for cancer patients, and education to clinical staff in those areas. So thrilled to have Belinda speaking, following on from Alison. And Belinda, I'll hand over to you to talk about trials and tribulations of implementing sepsis pathways.
Thanks so much, Fiona. Can everyone see my slides?
Yes.
Great, thank you. It is always very hard to follow up after Alison, because she is a wonderful speaker and really puts things into context at a global scale. And I am absolutely, I've got the big crush with Alison, because we've been working together for so long, and I'm very grateful that we are able to work together and inspire each other on our journeys. But I guess now I should probably start with my talk. The trials and tribulations of sepsis pathways in the electronic medical records. So before EPIC, as Alison mentioned, we actually adapted and developed the sepsis pathway at Peter Mac from the Clinical Excellence Commission Adult Sepsis Kills Pathway for emergency departments. And it was developed as a whole of hospital pathway, and it was called Think Sepsis Act Fast. Due to the improvements in the mortality, reduction in time to first antibiotic, and hospital admission costs, it was implemented at RMH, and then Safer Care Victoria funded a scaling collaboration where it was rolled out to 23 hospitals and 11 networks throughout Victoria, and it was obviously led by our very own Karin Thursky. So it was a very exciting time to think that Peter Mac was at the forefront of this work that has made a great impact across our state. And so I guess the first thing is to kind of try and put it into context in terms of how you move from a paper pathway into electronic medical records. And so a review of the literature demonstrates the complexity of this topic. We put together a PICO question, and so obviously the patients, we filtered that through to adult inpatients in acute hospital settings. The intervention was sepsis detection or management in an electronic medical record. The control was manual detection and ordering of clinicians' workflows manually, and the actions. And then the outcome was hoping that we could improve early detection of sepsis and timely management. The literature search found about 22 relevant papers. There was a scoping review. There was 6 systematic reviews. There was 7 retrospective interventional studies and 6 prospective sepsis alert studies. And the word cloud there, you can see, really does highlight the difference in the titles and what we were talking about, including some of the rules and how they managed to develop these tools. So moving on from that, thinking about the definition of sepsis. So in the literature, there was many different ways of defining sepsis. Some people used purely SIRS, systemic inflammatory response syndrome, to commence triggers. Others defined sepsis, severe sepsis, septic shock, and then sepsis confirmed with a blood culture. And many of the fields in terms of the areas were focused on intensive care or emergency settings, where we know that sepsis is very common, and it utilised different prediction scores as well as mortality variables and early warning criteria. So thinking about news, which is and news 2, and then the versions of that, which is news and trues, and there's lots of different acronyms there. There was SIRS, and then there was thinking about other criteria as well, including lactate, and the Bureau, in terms of mortality and prediction tools, there's the SOFA, the QSOFA, the LQ-SOFA, and the Bureau. But the vast majority of them rely on manually entered vital signs. So we tried to find a couple of papers that were most suitable to our setting, and the clinical decision support algorithms. And there was a particular paper, which is the TRUES paper, so Targeted Real-Time Early Warning System, and that was published by Adams et al, and it had quite a similar approach to us, which was looking at early warning criteria and then confirmation by a clinician of concern for sepsis or infection, and then rapid assessment and treatment. And so I'm hoping that the picture there illustrates that there's apples and oranges. You're not always comparing apples to apples. And so the types of technology, there was several computerized clinical decision support tools, and of the interventions we found, there were machine learning algorithms for diagnostic and prognostic purposes, and these interventions had varied next steps. They ranged from purely surveillance and silent monitoring to providing information to clinicians in the form of best practice advisories, while others, there was an extra step which looked at creating alert systems to ensure that the clinicians were aware of patients' condition. Some of those were to teams that were not at the bedside, whereas others were to the clinicians at the bedside. So escalating to consult kind of teams. So there was a lot of difference there. In the limitations of the evidence, very few of the computerized clinician decision tools were prospectively validated, and it was dependent on those variables being entered. Missing data causes that ineffective detection. Lack of generalizability in the electronic health records, including the predictive early warning systems. So, for example, there was a lot of homegrown type tools that were used. For example, EPIC has its own sepsis model, Cerner has its own sepsis model, and they were all kind of specialized. And so in order to be able to look at whether it's appropriate for your field, it's quite tricky, whereas others used more standardized tools. The poor recognition of sepsis patients, with around 30% of cases flagging by the alerts, and the majority of those alerts were post-administration as well. So that early warning doesn't appear to be in a lot of the electronic health clinical decision support tools. The complexity of determining time zero is another talk in itself, because really it is tricky to make that decision based on the information that you have, and retrospective audits can improve that, but we need to formalize those and get them into looking at predictive models in a better way. And that's where a lot of the evidence points to. Let's try and see how we can use this data to make it more prospective. And so coming back a bit locally, there was 4 very different hospitals that were implementing the electronic health record, and they were different in size, they were different in patient cohorts and specialties, and we were trying to make it a one-size-fits-all workflow in the EMR. The challenges that we needed to work through and overcome include different deterioration criteria, different empiric guidelines for antimicrobial prescribing, the conversion of a sepsis paper pathway into an EMR form in some ways really does miss some of the components that are crucial to ensure that there's early detection and early warning. And then a lack of usability testing to be able to understand how things would work because of tight timeframes and some other things that might have been going on in the background. And there was also very little training time allocated for the specialist workflows because it was purely just, let's figure out how we can do our basic OBS and documentation and find all our results and things like that. We were able to be involved in the video uploads of EMR workflows, but the distribution of that to staff was quite tricky because there was so much information overload. Not to mention a little thing called COVID. So just putting it into context as to when we did go live, we started work in February of 2019, looking at the workflow, and the planned go live was the 2nd of May in 2020. The pandemic was declared by World Health Organization on the 11th of March in 2020, and our go live in the final decision to change and put back the date was on the 27th of March, and the EMR was put into place in ED. The go live was on the 30th of June, but the whole of hospital and precinct was moved to the 8th of August. And just to put into context at that time, our peak numbers were actually on the 7th of August in 2020. We had 466 cases with 7,808 active, and that was the highest we'd obviously ever been at that point. We were in the middle of the hard lockdown, and we had just come off the hard lockdown in the towers. And so the pressure of staff with what was going on at the time on top of a brand new way of working was definitely impacting how things would work. And so what the build looked like was we had a flag on the patient storyboard, and then you needed to click onto that flag and it would say, does this person have a known or suspected infection? And then it would just be a yes or no. But in order to get the information about, making that decision, you had to click on a wrench so that you could see that. And then that would then open the hard BPA if you said yes, and that would then open the order sets. So there was lots of clicks there. And then that would allow you, it was role specific. So if you were a nurse, you could nurse initiate the observations, the 2 sets of cultures, the VBG and additional bloods. But then you had to change the ordering information to the clinician that you spoke to. So there was lots of additional information there that you needed to add in. So it wasn't a simple process. When it came to the initial management for the doctors, all of that other information was that the nurses had potentially put in was pre-selected as well. So they had to unclick all of that and then decide what they wanted to order. And so it was also, but the beauty of it was that it was the empiric guidelines were built out for them. They just needed to find that section. So that was how it was built, and that's when really the rubber hit the road, and you don't know what you don't know until day one, and how things are going to work and how staff are going to adapt and work through the workflow. So issues that go live, there was human and training factors that were involved. We knew that a vast majority of staff members were unable to have appropriate training prior to go live. They were unaware of the flags. They were unaware that that flag meant it was an urgent action. They felt that the wording was confusing because it was right on top of the infection prevention status in terms of transmission-based precautions. So it didn't flag as anything different. And the timing of the build, because of everything that was going on, it was literally days before go live when things were complete as they could be. And then you've got the technological and build factors defaulted to previous answer. So if someone had said no, it defaulted to that. So it wasn't questioning people at the time in the way that we had hoped. And the decision support was hidden. The roles and tasks weren't defined in EMR, so people were unclear who should be doing which actions. And as I highlighted before, the number of clicks was massive. So post go live, that's where the work started to begin. And a lot of it was done online because we were in lockdown, but monitoring the workflow, educating and interviewing staff to see what they worked, how they were using the EMR. We had a precinct sepsis working party developed. We improved, we had to find out what data we were getting from the workflow. Then we found out that there was different ways of working, and some people were using WOW, some people were using rovers, which are handheld devices. And so we had to figure out how to utilize both of those workflows. Then we discovered that the workflow wasn't live and accurate and able to work in different settings, including the ambulatory setting. So we started to work on that workflow. Then we updated and improved the flags based on the feedback so that it made more sense for people and they could utilize it. And then we discovered the sepsis care path, which was build to, and worked towards that. And so this is what build to looks like. So we changed the flag to that take action, red, so very different. And then it provided the information with how to respond to the BPA. We removed the sepsis pathway already commenced because we found that button was used inappropriately because of based on education. We were able to improve that. And we provided the information with what criteria the patients were meeting so that then it supported the nurses in being able to hand over to the doctors. And then the action buttons were there. We then moved to a 3 flag setup. So there was the initial setup, which is query sepsis take action. If some of the components were done, but not all of them, it moved to a sepsis pathway incomplete, and it lets you know which actions weren't completed in a timely manner. And then the final one is sepsis pathway active, when everything's finally done. And so this is the back end of that sepsis care path. And as you can see, the map is quite complex, but it does allow for manual people to be able to use the workflow as expected, utilising the order sets and the BPAs, but also manual ordering and collecting of the critical components in the pathway. That will then still trigger and flag if things are appropriate. And then they move along the pathway until they get to the end. In terms of reporting with the EMR, it's really important to ensure that we're able to see what's going on with the patients at a ward-based level and where people are at. And so we've got day-to-day patient lists, but also the compliance measures and reporting what has happened in places so that we can then look at working on quality improvement and working with areas about what particular issues they may be having so that we can improve those compliance and get patients better outcomes. So the key learnings, understanding workflows intimately, understanding the technology that you're using, understanding the way that things work on the wards, understanding the actions, the roles and the responsibilities of the workflow, understanding the limitations of the EMR. For example, having the two very different systems within the same one in terms of the encounters that patients are being entered into makes a real difference. The clarification around language and definitions, as well as the consensus on those, and allowing time for testing and deadlines and ensuring that you're able to do those things appropriately, but also allow for education time, and also the being at go live, making sure that there's enough staff around to see how things are going and to provide that support is huge. And sorry, my thing's moved. And that's my last slide, but I just wanted to acknowledge the great work and support of my mentor, Karin Thursky, as well as the Precinct Working Party, who have gone above and beyond in all of those days that were quite tough. We still wanted to put our patients first and make sure that the sepsis workflow was working for the staff and for the patients, so that we could get timely outcomes. And it's a continuous improvement cycle.
Thanks, Bel. It's a really fantastic presentation, and really highlighting those contextual challenges and taking us down the story of implementation. Really fantastic. I'm sure there are a lot of people who have seen a lot of opportunities there, perhaps for their own work environment. I can see that we have Marlies, who has her hand up. Their hand up here. So, Marlies, would you like to?
I'm sorry. I've pressed the wrong button here on the screen. I wanted to have a reaction there and clap my hands. It was really well done. Thank you.
Thanks, Marlies.
Both presentations was extremely well done. Thank you.
It is not for the faint-hearted to try and get to this point, and it's hard to explain to all of you just how many hours this has taken over the last year and a half. And we've been very fortunate in that sepsis has been deemed a critical workflow in the precinct. And because it was deemed a critical workflow, that allowed us to actually gain dedicated epic time. So this doesn't happen for many things. So we have had a fantastic fellow, Gavin Rule, who's worked with us fortnightly to continually adapt and understand it. And as I've said to anyone who's going to be doing anything in the EMR, they actually have to deep dive and understand how the EMR actually captures data, how the rules actually work, and how staff actually interact with it. And Maya is on here, and we're very aware of this absolute importance for creating role-based workflows in the EMR, because otherwise you're just flooded with this system, and people do all sorts of workarounds. So creating this concept of nurse initiation roles, and which we really wanted to retain, because I think that was a success factor for the Think Sepsis program. So thank you, Bel. It's amazing the amount of effort that's gone into it. Maya, did you want to say anything? We can unmute you.
Yeah, thanks, Kaz. Thanks, Alison. Thanks, Bel, as always. Really, really impressive work. And I think, the enormity of the potential, both for, nurse-led work, but also where we think about the contribution of nursing into large multidisciplinary teams, which of course is where the real sort of value add is in something this complex. But really struck by the opportunities from both of the talks. One around the opportunities that are coming up for more NP roles through funding that's coming from the Victorian Department of Health for NP scholarships. So I think it's a fantastic time to think about where else we might have NP roles in this space. But struck by both of the complexity that you both talked about, and Bel, particularly listening to your talk there and thinking, there's such an opportunity here to learn about, what are the effective ways of bringing workflow changes into something like EPIC, not just in sepsis, but all the stuff you've learned around what were the barriers to this sort of transition, and how we can share that across the organisation and organisations more broadly. But also, linking into the points you were both making about the complexity of definitions and data, and how, as nurses with a nursing lens, we think about what are the opportunities here for nursing to start thinking about what are the minimum data sets we need to have an eye to, so that we can demonstrate their contribution within that broad, complex sort of sphere. So more comments really than questions, but I think there are huge opportunities because of the work you're leading and the work certainly, Belle, that you've already done.
Thank you. I might hop in and do my talk, because I'll be able to answer some of the questions that have come up from Michelle. So I will share my screen now. So everyone can see my screen? Yes. So I had the great opportunity, first of all, to present to the National Coders Conference last week, which was brilliant, meeting a room full of documenters, which is so important. And also, I wanted to acknowledge Alice Basali, who is the Director of the Clinical Care Standards for the Australian Quality Safety Commission, and Jenny, who's provided me some of her slides today. So this has been a huge and important piece of work, and one can't underestimate the importance of it. The Sepsis Clinical Care Standard really, I guess, was inspired by the Antimicrobial Stewardship Clinical Care Standard. And in fact, there were members of NCAS on the Clinical Care Standard, ensuring that the two standards were entirely complementary and that they referenced each other. So the Clinical Care Standards are part of hospital accreditation, but they're actually a piece of work that ensures that a clinician understands what is best practice in looking after antimicrobials or sepsis, and that the patient equally understands what is required for them. If they were going to be treated by sepsis, what is the best standard of care that they should have? And I want to make it clear from the outset that the Clinical Care Standard is not the clinical pathway, and there has been no mandated recommendations of what the clinical care pathway is going to look like. And to reassure all of you that the clinical care pathway approaches that are already in use, for example, the Sepsis Kills in New South Wales and the Queensland Sepsis Pathway and the Think Sepsis Pathway are still fully supported. And while we would like to have a national approach, individual approaches are still entirely appropriate, because really it is about building in pathways of care. I know your comment around SIRS. This is, I think, what we need to recognise is that, and Belle mentioned it before, early warning criteria such as SIRS and NEWS are still very important. And we were able to demonstrate in Victoria, with a combination of early warning and severe criteria, a reduction in mortality of 50% on patients managed on the pathway. There is no reason to stop using early warning criteria, and whatever we use, for example, NEWS 2 is used in UK, we need to be recognising that early warning remains an important component. That is not QSOFA, and QSOFA has now been not recommended. So in the absence of anything else at the moment, including commercial-based programs such as EPIC and Cerner, that there is still absolutely a role for early warning criteria, and that's important. So if you hop onto the website, there are these fantastic resources. So the Clinical Care Standard really consists of a number of quality statements, and really it revolves around, could it be sepsis? What is the time critical management? How should antimicrobials be managed, particularly in choice and timing? And this is the real key, recognising that sepsis is a whole of hospital issue. How do we coordinate care and transitions of care from community to ED to ward, ward to ICU, ICU back to ward, and ward to home? How do we educate the patients and carers that we need to use the word sepsis in our discussion with patients, and to maximise and optimise clinical communication, including documentation, and then to recognise that patients have long-term issues after sepsis. So really they are to assist the services to oversee and make sure that their sepsis programs fulfil all these criteria. And it's very hard to actually put hard and fast indicators, and there was lots of work to try and work out, well, what is approximate, how can we measure these things? So there was much discussion around that. But these, I think, will be very, very practical. They're also not mandatory at the moment, so we have not set any targets or benchmarks. So I've talked about this before, but when you're implementing anything, you need to think about what are the structures that you need to put in place. And so that might mean having a clinical care pathway, which is a medical record document. You may have a dedicated nurse practitioner role, sepsis teams. So you might have a particular clinician who's in charge of sepsis. So what are the local arrangements for sepsis? So what do you have in place? The second thing is sepsis structure and process. So processes are really the activities, and these are really the bundle elements of the clinical sepsis pathway. So oxygenation, putting in a cannula, having your 2 sets of blood cultures prior to antimicrobials, appropriate antimicrobials and antimicrobials within 60 minutes. So this is what we call process measures. And then finally, the outcome measures. So structure plus process equals outcome. What are the health outcomes that we're going to be measuring? What is the outcome of inpatient sepsis, death, readmissions, for example? I'm going to talk about the clinical documentation and coding, but you cannot underestimate how important this is in terms of being able to undertake surveillance, but also for the coders to accurately represent the type of sepsis the patient may have, including septic shock. This will be a continual improvement process. So just quickly whizzing through these quality statements and indicators, they're obviously all available. Really, the sepsis is recognising, first of all, that it recognises sepsis 3 criteria, and that sepsis is a response to infection. And this is a continual thing that we need to remind people that sepsis, there needs to be a suspected or known infection to actually have sepsis. And so therefore, assessment of vital signs and lactate is really important, and early escalation. As a most objective measure, it really is about introducing the concept of lactate, and this has also been prioritised in the Surviving Sepsis campaign, which was updated in, I think, 2021. Time critical management is really key here. It underpins the entire response to sepsis. So part of it is to actually have a sepsis clinical pathway, which inherently will drive bundles of activities at certain time points by certain time points, and that it supports that process. So this is moving away from the concept of a sepsis guideline, empiric clinical guidelines for sepsis. This is moving to a structured clinical pathway approach. And so monitoring patients treated with a pathway is how we approach it. At Peter Mac, we know that clinicians do workarounds on an EMR, but we have structured our data collection for the sepsis pathway to be activated if the bundles of actions are done, even if it's done outside of the order set. Antimicrobial therapy, obviously, there was much discussion around this, but absolutely, and in line with the Surviving Sepsis standards, we have continued with the 60 minutes if there is infection-related sepsis. Obviously, as you know, if infection is unclear and that further workup is required, then this can be extended out to 3 hours. However, if there is suspected on an infection, it is 60 minutes to first dose of antimicrobial. Indicators associated with this blood cultures and then timing. Transitions of care and clinical communication, clearly very important, something which we know is not inherently done so well. And many of the senior ICU clinicians who are on the working group and the patient advocate on the working party, there was much discussion about the fact that they realised that this was something perhaps not that well done. So again, it comes down to sepsis, which I'll discuss in the next bit, documentation, big pardon. Care after hospital and survivorship is fundamentally important. And from our patients, they've often said to us that no one told them that they had sepsis until they saw the discharge summary. So open communication with the patient about the fact that their infection was associated with sepsis and that they may have long-term ongoing effects, including post-traumatic symptoms and other long-term psychosocial cognitive impacts, is actually really important. And I can say that I think that there is much work to do in primary care in how GPs can be engaged in sepsis from their end as well, the uncertainty that patients who may have sepsis have in terms of getting them into the hospital and managing them early. So I guess the most objective indicator was really unplanned readmission. And then finally, the inpatient mortality, which is obviously available through coding. So they're the clinical care standards. And just before I go on to coding, I did want to reiterate why AMS and sepsis are so important. You know, I do a talk around sepsis and stewardship being two sides of the same coin. And that is actually, and if we recognise that 90% of sepsis comes through the emergency department, this is where some of our most broad spectrum antimicrobials are commenced, and we need to be embedded in any sepsis pathway program that your hospital is going to be doing. So as part of the recognition and reinforcing again that it's due to an infection, the patient is going to need antibiotics, it's important that we ensure that appropriate microbiology is taken, particularly the 2 sets of blood cultures before and any appropriate tests afterwards. In terms of resuscitation, there is many things that stewards can do. We can ensure that the empiric guidelines recognise patient allergy status, infection severity and dosing. And if you think about community-acquired pneumonia as being the most common cause of sepsis coming in, it accounts for about 40% of all sepsis. Documentation of severity clearly impacts which of the empiric guidelines they're going to be, empiric antis they're going to be given. And it should be underpinned by your local formulary and your approval program approvals, of course, for restricted antimicrobials, and then the timing. This is a fundamentally important component of sepsis in that there needs to be early recognition and referral, and that means source control by surgery, ICU liaison review or admission to ICU with severe sepsis or septic shock, and engagement of ID, particularly early on in patients known to be colonizers-resistant organisms or known to have one infection due to one. And then, of course, the post-acute phase. This is where AMS comes into its own because we are fundamentally important for antimicrobial step down, either stopping, reducing spectrum, etc. And then patient care education, how these patients who actually have an infection, who is going to be following them up, that they understand that there may be long-term sequelae that will need attention, and the post-discharge planning. So all this is fine, but we need to remember that in order to have continuous improvement in sepsis, we need to be making sure that we're collecting data in a standardised way. This has been a major issue for all of us working in sepsis, is that and I'll go through it, but it is actually really quite challenging, and we need to start to think about, again, a learning health approach here, that we are collecting data so we can aggregate the data and we can use this data to influence how we implement sepsis, and then to take that knowledge to continually improve practice and continue to measure. We are not there yet. And this is because sepsis does not have a pathological reference standard. It is a dysregulated host response. There is no single gold standard definition. There is subjectivity about whether infection is present sometimes, and whether the organ dysfunction is due to something else. Creates huge issues, and of course is a simple reason why I didn't want to spend this journal club talking about diagnostic or clinical criteria, because we'll go around and around forever. But we do know that there will be significant changes in incidence just simply on the way that sepsis cases are labelled and coded. And that requires that there is an understanding of the definition of sepsis, that there is accurate documentation by clinicians, and that the clinical coders can accurately translate the clinical notes. So on the back of that, we now need to think about how we do that. The Global Burden of Sepsis paper published in The Lancet a few years ago reinforced the importance of using both explicit and implicit coding for sepsis. And using these can significantly change the estimates of sepsis incidence. So, you know, ICD-10 coding always underestimates the rate. And so I'm recommending that we should be using both explicit codes, which are really such as, and I'll show you soon, but it might be, you know, enter staph bacteremia, sepsis due to staph bacteremia type codes, which are the sepsis codes. But we also need to think about implicit coding, where we combine infection codes with evidence of organ dysfunction so that they aren't simply related to the bacteremia type coding that has underpinned a lot of ICD coding, as well as combine some R codes, which are previously the SIRS and septic shock codes. And the reason why, you can see from here, this was a publication by Jake Valentine, who worked with Peter Mac, which showed that there's a big difference between using clinical data, explicit coding, implicit data. You can see that there is a significant increase ascertainment of sepsis cases if you're using implicit coding as well. So the ICD-10 coding standard has now been updated to reflect the sepsis 3 definition. And we previously had a 65-1 code, which is 65 codes, which were called SIRS, and they have removed the severe sepsis to have both, and now to have sepsis and sepsis shock. And you can see on the right-hand side the A40 codes, which really include the word sepsis as part of the bacteremia. Again, these are very pathogen level coding definitions and just to reinforce that concept of implicit coding. When you have pneumonia and sepsis, or urinary tract infection and sepsis, this is where it becomes very important to consider those implicit coding ways. Now, the other thing is, previously coders would have to go through and look for other signs of sepsis. So they'd have to look for evidence of sepsis, such as lactate or hypertension or altered mental state. The sepsis codes now include those elements. So on the right-hand side, you can now see that sepsis due to strep and enterococcus include and assume that the patient will have altered mental state, hypertension, tachypnea. Septic shock as a code relies on the fact that that patient would need inotropes to maintain an ICU admission to maintain blood pressure. And so that's an additional level of severity. So coming back to this, and this is very relevant to all of us online now, they will no longer accept the words sepsis, such as urosepsis, the sepsis, biliary sepsis, bloodstream infection. There needs to be absolute documentation of sepsis rather than septic to be coded as sepsis. I realise I'm actually going way beyond time here, so I'm just going to quickly finish up here. And just reinforcing that E. coli urosepsis, you need to, if with the word urosepsis, that would not be coded as sepsis, it would just be UTI and E. coli. However, if you actually include the term sepsis, it will then be fully coded, and that obviously has significant implications. And my last slide is the fact that they've now included new codes now to reflect antimicrobial resistance, which is a much expanded to what we had before. So just remember that as well. That needs to be documented. So really the key points are important to take back to your organisations around being very specific about the term sepsis, and that terms such as urosepsis will no longer be coded, and that that residents and clinicians should be documenting all antimicrobial resistance within the clinical notes. So I'll leave it there. I'm sorry that I've gone over. It was a big session today. So I'll stop there.
Kaz, it was a big session, but what a powerful, impressive session it's been. I'm mindful of time, so I just thought I'd make a comment.
Everyone stayed on. So
everyone stayed on, which shows how significant it is. I'd just like to point out for those nurses online, the sepsis clinical care standard was endorsed by around 25 or 26 organisations, including 4 or 5 nursing organisations, and the College of Nursing, emergency nurses, critical care nurses, and rural and forgotten the full name, the Cranner group. So that's worthwhile noting, I think. Look, it's just been such a powerful morning, looking, at the power of nurses and indeed midwives, I think, and the opportunities there. From Semmelweis, who'd be amazed at the technology available now through EMR and what can be done. But really, I'm just struck by the leadership of nurses across time and what can be done. Still many challenges, but there have been a lot of opportunities identified here today. So if anyone would like to stay on for a couple of minutes and ask any questions.
Thank you so much, Fiona, and also for your leadership as well with nursing and MS. I've got to jump off because I'm also 5 minutes late from my meeting, but thank you so much for you. And also for our presenters. I think we obviously have a recording there, everyone can catch up with it. Thank you.
Thanks, Kaz. Thanks, Fiona. Thanks, Belinda. And thanks, Alison. Yep, so recording will be on the website later today. Also on the website, we've just announced the Antimicrobial Awareness Week program. So that's live, it's on Twitter. We are running a hybrid symposium on Friday, the 18th of November. That will be in person and available online for those unable to attend in person. And then for the rest of Antibiotic Awareness Week, we will have free online webinars. So go to the NCAS website. I will put the link in the chat. Yeah, we hope to see you all again online, whether it's for our other journal clubs or at Antibiotic Awareness Week. Thanks, everyone.